My name is Audrey Summers. I'm one of the PGY2 residents, and I am going to be doing my journal club today on an article about a new drug used for postpartum depression. All right, so just to start out with, I have no conflicts of interest to declare. And here are our goals and objectives. I kept them pretty short just because we have a lot to cover and I didn't want to overwhelm everybody. So I'm just going to talk a little bit about postpartum depression and current treatment options for that currently. And then I'm going to jump into the actual journal review. And it is a drug called zuranolone that's not FDA approved yet. So we're going to be talking about that. And then we'll also discuss the limitations and applicability of this drug in the clinical setting. And then we're also going to compare and contrast zuranolone to brexanolone, which I will tell you about here in just a little bit. All right, so I'm just going to start out with kind of an overview of postpartum depression for those of you who don't know much about it, and just to educate our medical students. So through my research on this topic, I actually found that 85% of women experience some kind of mood disturbance in the postpartum period and actually during pregnancy as well. Not all of that has to be necessarily pathological, but there are, most women experience this during pregnancy and thereafter. And the prevalence of postpartum depression itself is about 13% per year. All right, so here is the definition of postpartum depression, and it's in the DSM-5. It is defined as a major depressive disorder that is identified during pregnancy or within 4 weeks postpartum. So that's kind of the timeline that they use. Sometimes they say it's only in the third trimester to 4 weeks postpartum, but I think most sources identify it during pregnancy or 4 weeks postpartum. And then some experts actually extend this to about a year because we know that women continue to have hormonal changes through a year after pregnancy. So that is something just to keep in mind. But that's not technically the diagnosis with DSM. It has the same criteria for major depressive disorder. So as you guys know, depressed mood for at least 2 weeks and at least 5 of the 9 other symptoms, which includes disinterest, low energy, poor appetite, sleep disturbance, psychomotor abnormalities, hopelessness, guilt, poor concentration, and then suicidal thoughts or ideation. So your typical SIG-ECAPS type symptoms. And then the definition is the diagnosis is a little bit complicated. There is a specifier in the DSM-5 that indicates with peripartum onset. So this means before delivery. So you can say peripartum depression as well. I think they interchange the use of the words peripartum and postpartum because postpartum infers that it's after delivery, but it can actually be during pregnancy as well. So that's why they have that specifier in there. And then I put these stats up here just to kind of indicate that 50% of postpartum depression starts before delivery. So really including that peripartum onset is important. And then I did want to, for the students, because I know this is a big thing that they're tested on, the difference between postpartum depression and baby blues. So baby blues is a little bit milder than postpartum depression. There are symptoms like mood lability, anxiety, irritability, usually starts a few days after delivery, and then it usually resolves within 2 weeks. And then there's not a lot of impact on functioning like there is in postpartum depression. All right, so moving on to the causes of postpartum depression. So during pregnancy, your estrogen and progesterone levels rise significantly, and the progesterone actually peaks in the 3rd trimester. And then within 48 hours of delivery, the progesterone actually significantly declines. So this leads to disruption of perinatal GABA by dramatic changes in circulating allopregnanolone. So allopregnanolone is a metabolite of progesterone, which I will actually show you guys in a chart later. Allopregnanolone is the neuroactive steroid that we'll kind of be talking about today. So low levels of that after delivery or even during pregnancy, sometimes disruptions of that can lead to postpartum depression. So in my research, I actually saw that women are actually that are more sensitive to hormonal changes, such as women with a history of PMDD or thyroid disorders are actually more at risk for these hormone shifts during pregnancy and could be more at risk for postpartum depression. But there's, we can't say that hormonal shifts correlation doesn't equal causation. So we can't say that hormonal changes always cause this, but it is a big theory into what the theory of what causes postpartum depression. There are other things that cause it, such as marital dissatisfaction, inadequate social supports, and stressful life events. So obviously, during pregnancy and postpartum, your body is changing a lot and there's a lot going on. And even after you give birth, it's a huge adjustment to your life and you're having to kind of navigate how to take care of yourself and also how to take care of this new baby that you have. So social factors play a huge role in that as well. And then, of course, if you have a prior history of MDD or bipolar disorder, this can also put you at risk for developing postpartum depression as well. Okay, so we're going to talk about who is more at risk. Really, all peripartum women are at risk for postpartum depression. Of course, there are some protective factors, but in the purple boxes here, these are the major risk factors in developing postpartum depression. So if you've had a previous episode, you have about a 30 to 50% risk of developing it again in future pregnancies. And then depression during pregnancy, of course, that's kind of vague. History of MDD or bipolar disorder. And then, of course, the social factors that I talked about, this puts you more at risk. And then I actually came across a study that was really interesting that said that if you have obesity, it puts you at higher risk for developing postpartum depression as well, compared to women who were not obese. Right. So I wanted to spend a few minutes talking about the screening for postpartum depression. So there are many scales that that providers use for this, but the Edinburgh Postnatal Depression Scale, or the EPDS, is the one that's used most often. So this is given, it should be given at every outpatient visit after you deliver, and women should be answering this each time they come into the office. It's self-administered, and there's 10 questions. So a score of 12 or an affirmative answer on question 10, which is about suicidal thoughts, is a positive screen. So usually they use the screen up to 4 to 6 weeks after delivery. And this can be done by the OBGYNs. This can be done by a psychiatrist. This can be done by a family doctor. So really, no matter what kind of setting you're in, you should really be giving all of your postpartum patients the scale so that you're not missing anything. And then I will talk about a little bit about 10. So if anybody answers yes to this question, or sometimes, it is something that you have to ask a little bit further about, or, immediately send them to the emergency room or have them evaluated by a psychiatrist, because, the suicidal thoughts are obviously dangerous, and you want to make sure you do a proper suicide assessment to make sure that nobody's going to hurt themselves. A lot of women also can have homicidal thoughts towards their baby. So that's another question that you want to ask if they screen positive on this question. And then obviously refer back to this paper later if you would like to. Okay, so we're going to talk a little bit about different treatments that are currently available for postpartum depression. So there's actually quite a bit. You have your different therapies, such as cognitive behavioral therapy and interpersonal therapy. So CBT, in one of the studies I found, is actually shown to be more effective than or as effective as Prozac use in pregnancy or postpartum. So that's pretty interesting. But we all know that therapy, works really well for depression. So that is, these are pretty accessible things for our patients. Interpersonal therapy really focuses on the relationships in someone's life. So if someone's having like marital problems, or if they're having problems like with social supports, interpersonal therapy might be more appropriate. And usually it's used in more mild to moderate postpartum depression. The other options here, we have the antidepressants, which you guys all know and love, our SSRIs, SNRIs. And then I put kind of some dots out here because TCAs and MAOIs can also be used, but they're generally avoided due to their risky side effect profile. So there is a ton of research on SSRIs and all these medications used in pregnancy. I'm not going to get into that today. That is another talk for another day. But I just wanted to make sure you guys knew that that was kind of one of the things that is mainly used to treat postpartum depression as of right now. TMS can also be used in pregnancy. Like I said, I didn't spend a lot of time on this, but it is something that's safe and can be used. And then ECT usually is used in more severe or refractory cases of depression or postpartum depression. I personally have not had any pregnant women on our inpatient unit so far during residency get ECT. I think there was one at Norton that we tried to do this for, and I think maternal fetal medicine had an issue with anesthesia. So there's always risks with that as well. And then antipsychotics obviously can be used if psychotic symptoms are also present. So I'm actually not going to talk about antipsychotics or postpartum psychosis hardly at all in this presentation, because the study that I am covering does not actually excluded people who were having psychotic symptoms. So we're going to just kind of skip that. I just wanted to make sure I cover my ground. And then brexanolone. So I am actually going to move into that right now. Many of you guys probably have maybe heard of this through the grapevine, but it's not something that's commonly used, at least here in the university setting. So brexanolone, the brand name is called Zulresso. It is a 60-hour infusion of, it is the IV form of allopregnanolone. So it's chemically identical to allopregnanolone, which is the neuroactive steroid that we create in our bodies naturally. So Sage Therapeutics actually created this, did 2 randomized double-blind placebo-controlled trials. And I will talk about the results of this actually a little bit later when we compare it to the zuranolone. But I will say, you know, it does have the same, a very similar structure and the same mechanism as zuranolone. So just to clarify before we move any further, brexanolone is the IV form of allopregnanolone, and zuranolone is the oral form of allopregnanolone. So they're essentially very similar, but they are just, they're different routes of administration. So brexanolone is given as an IV infusion for over 60 hours. They usually start it at about 30 mics per kg per hour, and then they increase it to 90, and then they taper back to 30 once the end of the 60 hours is approaching. So this medication actually requires quite a bit of criteria for women to receive this. It requires monitoring every 2 hours by a healthcare professional. The treatment has to be initiated early in the day, so it's tolerated well. They also have to be on continuous pulse ox to monitor the oxygen saturation, and another caretaker is required to take care of the baby due to the sudden loss of consciousness risk of this drug. So after the FDA approved this, they actually enrolled it in the REMS program. And this is just to monitor use of this drug because it does have a risk of excessive sedation or sudden loss of consciousness. And that's why these patients are monitored very closely. One of the major limitations to this drug is actually it's 5 vials of this medication. Usually you need 5 for the 60-hour infusion, costs $34,000 itself. And then you obviously have to pay the fees for the infusion management. So, you know, you have to pay if you're going to be admitted to a hospital and do this, or an infusion center, you have to pay for all the staff, taking care of you, and all the, supplies and equipment they use as well. So it can actually be pretty expensive. I did talk to someone who told me that insurance does sometimes cover it. I don't know all the details on that. We don't use this in the university setting. And I'm not 100% sure if anybody in Louisville uses this treatment, but I think there are a few in Southern Indiana who use this. All right, so now we're going to move to the actual study. So this study was published in JAMA Psychiatry in 2021, and it is the original investigation or the original clinical trial for the effect of zuranolone versus placebo in postpartum depression. All right, so Sage Therapeutics, they are the company who has done the clinical trials, and they did brexanolone studies as well. So it's actually really interesting. They call their studies on postpartum depression called the BIRD studies. So this one in particular is called the Robin study. And so that you might hear this interchanged. If people are talking about it, you might hear zuranolone referred to as the Robin study. So this is the original one. They also have some studies going on that talk about zuranolone in major depressive disorder. So they actually separate the major depressive disorder from the postpartum depression. So, like I said, there's a lot of information out there, and I won't be covering the major depressive disorder studies today. Okay, so just to talk about zuranolone a little bit in the structure. So zuranolone, and they also call it Sage 217. It is a GABA A receptor positive allosteric modulator. Sometimes positive allosteric modulator is referred to as a PAM. And here is the GABA receptor up here. And as you know, chloride moves through it when it's, stimulated. And then zuranolone is given as a once daily dose of 30 milligrams, usually at bedtime with food. And I did want to put in the structure. So this structure right here is zuranolone, and it is the oral, it is an oral equivalent to allopregnanolone. And as you can see here, it's structurally similar right here, but then zuranolone actually has this group attached where allopregnanolone does not. And I did not find any studies on this, but I would assume that it's to make it more bioavailable because allopregnanolone is not usually readily bioavailable. So I just wanted to mention that. And the binding site of zuranolone is distinct from benzodiazepines. It modulates both synaptic and extrasynaptic GABA A receptors. So there is a low, there's not much to worry about with the addiction potential because it works in extrasynaptic GABA A receptors as well. So just to mention, you guys know this from probably a while ago, but cholesterol creates progesterone, and then progesterone creates allopregnanolone, through the cycle in your liver. So progesterone is the major hormone of pregnancy. And like I said before, it peaks in the third trimester, and then after childbirth, it rapidly declines. And so there is a theory that the level of allopregnanolone actually drops quicker in women who develop postpartum depression than those who do not. And the literature has been saying that this could be from abnormal neurosteroid enzyme expression, and the GABA receptor function may fail to adapt to this rapid decline in allopregnanolone in the weeks following childbirth. So just something really interesting. The mechanism of postpartum depression is a little bit different from major depressive disorder and other mood disorders. So I find that completely fascinating. And I think that's something that will come more to light as time goes on as well. All right, so this is just a little chart that I actually found from Sage. It just shows you the extra synaptic receptors with this, this delta subunit. and the positive allosteric modulator here and where it binds. And then it creates a tonic GABAergic current instead of a phasic current, like a benzo would. Okay, so the question of the study is, does treatment with zuranolone reduce depressive symptoms in female individuals experiencing postpartum depression? Okay. So just to mention the methods for just a few minutes, this was a 2-year study conducted from January 2017 to December 2018. So pretty recently. Patients were screened at 33 centers, and then only 27 of them randomized and dosed at least one patient. I'll get into the criteria on the next slide. And then there were 153 patients that were randomized 1-to-1. They either got 30 milligrams of zuranolone or they got the matching placebo capsule for 2 weeks. And the study was also double blinded. Okay. So the criteria, we have the inclusion and the exclusion. So in order to be included in the study, you had to be 18 to 45 years old. This was a women-only study for obvious reasons, and you had to be less than 6 months postpartum. Your HAM-D score had to be over 26. So HAM-D was the depression screen that they used. This was their major scale that they used in the study. And I will show you guys that in just a little bit. So their total score on the HAM-D had to be 26 or above. They also had to have a major depressive episode without psychosis diagnosed by the DSM that began no earlier than the 3rd trimester and no later than the first 4 weeks following delivery. So the study was really wanting to follow strict criteria of postpartum depression. They had to stop lactation or breastfeeding for 21 days. So essentially day 1, taking the pill, and then for about a week after receiving the medication, they had to stop breastfeeding. And then they also had to have a negative pregnancy test, obviously if they were postpartum, because if they were peripartum or before delivery, they obviously would be pregnant. And then the other interesting thing was they had to either not be on an antidepressant at all or on a stable antidepressant dose for more than 30 days so that, there wasn't any confounding, variables there. So that was pretty interesting. And then some of the exclusion criteria, active psychosis, bipolar disorder, schizophrenia, or schizoaffective disorder, history of seizures. They also excluded everybody who had a substance use problem within the 12 months prior to screening. So everybody who did the study were using no substances or had been at least 12 months sober. And they wanted to make sure, there weren't, like I said, any of these like compounding variables. And I think this is also to make sure that their depression wasn't substance induced as well. Okay, so just to mention and just to show you guys the HAM-D 17 scale. So this is a self-administered depression rating scale. Patients fill this out themselves. They rate all these things on a scale from 0 to 4. And then at the end, they add it all up. And like I said, to be included in the study, their score had to be a 26 or above. And this questionnaire actually, they just do it to 17 questions, but there's another version of it that goes to 21 questions, which is shown here, but they did not do the HAM-D 21 for this particular study. But I just wanted you guys to know that the HAM-D 21 did exist. All right, so we're going to kind of go through the trial now. So this is just a little overview in the design of the Robin study. So I'll get into more detail about this when we move forward, but there were 151 patients that had severe PPD. This was the safety population. And then they were divided into 2 groups. One group got zuranolone, 30 milligrams, and one group got placebo for 2 weeks. So they took the drug from day 1 to 14, and then they stopped. And then the study's primary endpoint was at day 15, and their primary endpoint was the change in baseline of the HAM-D score at that point in time. And then they had a bunch of secondary endpoints, which I'll get to in just a little bit. And then they followed up on day 21, and then they followed up on day 45, and then they did not follow them after that. So it was just a 45-day follow-up period. All right, so like I said, I kind of mentioned this before, you either got placebo or zuranolone 30 milligrams given once an evening with food for 2 weeks. And then some people were unable to tolerate 30 milligrams, so they actually decreased their dose to 20 milligrams. And then all follow-up visits were in an outpatient clinic setting, so no hospital type work done here. And then, like I said, they were followed days 1 through 45. Okay, so like I said before, the primary endpoint that they measured was the change from baseline in HAM-D 17 score at day 15, so the day after they stopped taking the medication. The secondary endpoints include change from baseline in HAM-D total score at other time points, so they measured this at days 3, 8, 21, and 45. And then they also did the MADRS score. So that is the Montgomery-Asberg Depression Rating Scale. I'm not going to go through this because that wasn't one of the major things they talked about. That's just another depression rating scale. And then the HAM-A score, which is the Hamilton scale for anxiety, which I'll have a chart on this I'll talk about later. And then they measured the HAM-D 17 response and remission. So this is important. So this response was defined as a 50% reduction in score from baseline, and then a remission meant that your score was less than 7. So that's pretty, just keep that in mind as we move forward, because that will be important for the results section. They also measure the CGI response, which is called the Clinical Global Impression Improvement, and then the BIMF, which is the Barkin Index of Maternal Functioning. This one I had actually never heard of. It's it kind of talks about maternal functioning as a whole and whether it improved or not. So it's just something interesting that I thought when I was doing my research on this. And then I just wanted to put in here, they did define serious adverse events as a medical occurrence that resulted in death, life-threatening, required inpatient hospitalization, resulted in disability, or was a congenital anomaly. So these are some of the things they did for their statistical analysis of their data. So, you know, I won't talk about this for too long. They use the two-sided t-test to, you know, provide 90% power, and they adjusted for placebo for this. And then they also use mixed effects models used for primary and secondary endpoints. They also use model-based point estimates, 95% confidence intervals, and then of course, you know, all the p-values are reported. All right, so let's get into the kind of meat of the study. So this is the consort diagram of how these patients were divided. So there are 275 patients that were enrolled, and then they randomized 153 after they let go of all the screen failures. And then, so in the zuranolone group, 76 out of 78 completed the treatment. There were 2 that got lost due to one was an adverse event, and then one was noncompliance. And then actually 3 of those 76 patients reduced their dose to 20 milligrams. And then in the placebo group, 72 out of 73 completed treatment. So that was about 99%. And they lost 1 patient to follow up. And then 1 person actually did not complete like the post-baseline efficacy assessment. So they just had to report that. So what we're looking at is really the safety populations here. All right, so here are some of the demographics of the study. They had a mean age from about 27 to 29 years old. There were actually quite a few women who identified as Hispanic or Latina in the study. And as far as race goes, it was pretty almost equally divided between white and African American, and there weren't as many people in the other category, which includes Asian, Native Hawaiian, Pacific Islander, or if they were biracial. So there weren't that many in that group. So that was kind of interesting. And then they did the weight, the BMI, and then the baseline antidepressant use. So like I said, some of the women had to, if they were on an antidepressant before starting the study, they had to be at a stable dose for at least 30 days. So there were 16 people in the zuranolone group and 13 people in the placebo group. So about 21% of people in the zuranolone group had been on an antidepressant already, and 18% in the placebo group had were on an antidepressant before starting the study. And then it does show you kind of it's pretty evenly divided on whether these people were in the third trimester of pregnancy or whether they were postpartum. So it included kind of both. And then family history, and then did show the baseline HAM-D score. So the baseline was about 28 in both groups. So that was a pretty good. All right, so the outcomes. So here is the right here at day 15. This was their primary endpoint. So they did find that treatment with zuranolone did meet the primary endpoint with statistical significance. They did have a change in baseline of HAM-D scores at day 15, achieving both response and remission. So like I said, response is a greater than 50% reduction in score from baseline, and then remission meant you had a score less than 7. So remember, many of these women, the baseline score in each category was 28. So they did have most women had a decrease in baseline from that. So the response rate was 72% in zuranolone group and 48% in placebo. And then the remission rate was actually 45% in zuranolone and 23% in placebo on this day. So the really interesting thing that I'll go ahead and mention that I'll talk about a little bit later is that there were pretty high placebo rates in this study. And what's interesting is they had pretty high placebo rates also in the brexanolone study. And actually the placebo rates got even larger as time went on. So at day 45, the placebo rates were higher than they were initially, which is pretty interesting. So then I'll kind of move into the other secondary endpoints, but as you can see, the zuranolone had a larger change at all time points during the study, and they did meet, their secondary endpoints here as well. So, pretty interesting stuff. All right, so here are a couple charts. So this first one just shows the HAM-D response and the HAM-D remission. It's a little bit hard to read, but it's just basically showing you can really see the placebo, like how the placebo response and the remission rates were compared. Like they're still pretty high, which is at every time point. But like I said, see, like here, the response of placebo at day 3 is way lower than it is at 45. So like I said, the placebo rates will increase kind of over time as time went on in the study. And then the zuranolone response obviously did too. So it did show that it was working it improved the HAM-D score. All right, so another chart to keep in mind is the HAM-A score. So very similar looking to the HAM-D. So, at every time point, days 3 through 45, they saw, a significant reduction in HAM-A scores than from baseline. And they were observed, improvements in anxiety symptoms across all days. So it's interesting because GABA is a major player in anxiety. So this likely plays a part in that. So zuranolone might alone help with anxiety as well. So that's just something big that I wanted to mention and show you guys. So a couple other things that they found, there was a sustained reduction in the MADRS score with zuranolone versus placebo at day 15, and then as well as an improvement in that CGI-I response. And then at day 3, there was actually a higher percentage of zuranolone response compared with placebo. So it's pretty rapid acting, which is pretty interesting, just like brexanolone. So I'll get into kind of the discussion later, but I just wanted to mention that. All right, so some of the other results. This was something that they didn't really talk about in the study, and something that I would personally like to know about a little bit more. But during the follow-up period, only 4 patients in the zuranolone group and 6 patients in the placebo group had new antidepressant treatment initiated by investigators. So it's very unclear if these people had already been on an antidepressant and they got on another one during the study, or if they had no antidepressant before. But this kind of raises the question whether, was it the new antidepressant that they started, or was it the zuranolone? Even though there's only 4 in one group and 6 in the other, so a relatively small percentage, but it's a relatively small study, so it's hard to know exactly, and just something to kind of question. And then, like I said before, sustained reductions from baseline in HAM-A and MADRS score in zuranolone versus placebo. And then the BIMF actually increased for zuranolone versus placebo at all time points with statistical significance at day 45. So that's that maternal functioning scale. So maternal functioning also increased over time, and more so in the zuranolone group than the placebo. There could be multiple things for this. I think, women have initial hard time adjusting to having a baby, but, as they adjust a little bit, and they spend some time at home and kind of get things situated, I think that also improves. So it's hard to know whether that was a confounding variable or not. All right, so this is about the safety and tolerability of the drug. So, like I said before, any adverse event had to be documented. There were about 60% of women in the zuranolone group reported an adverse event, and about 52% of women in the placebo group experienced an adverse event. So there were only 3 severe and 1 serious, and we'll talk about that in just a second. So the really interesting thing that they saw was actually the adverse effects in the groups were different. So in the zuranolone group, somnolence was the most common reported side effect, and then in the placebo, it was headache. But there were a lot of things that were seen in placebo that weren't seen as much in the zuranolone group. So in the placebo group, 4 people had abnormal dreams and 4 people had hyperhidrosis, and no people had this in the zuranolone, which is really interesting. And then more people actually had GI effects in placebo than they did in the zuranolone group. Well, maybe the diarrhea more people in zuranolone did, but the nausea and vomiting more people had in the placebo group. They did have more sedation in the zuranolone group, which is actually, it kind of goes along with brexanolone. They did have more sedate. They did have, they are involved in the REMS program for this. Just pretty interesting that there were a lot of differences in the 2 groups and what adverse effects were reported. So the severe adverse effects in the 3 up here, the 3 people with the zuranolone, one of them had sedation, one of them had a confusional state, and then one of them had a migraine. And then the 3 in the placebo groups, so they were equal severe adverse events. One of them had back pain, one of them had headache, and one of them had menorrhagia. And then the 2 serious ones, so the serious adverse events were also equal in both groups. One person in the zuranolone group had a confusional state at day 3 with sedation, which resolved in 7 hours. So they stopped the dose for that one day, and then they were able to decrease it and continue taking it every other day after that with no issues. And then the person in the placebo group, the serious one was they developed pancreatitis and on day 32 and then resolved on day 36 with cholecystectomy. So probably not related to, the drug. It was probably due to gallstones, as we all know. So, and then one person actually stopped the zuranolone drug due to intermittent sedation, but there were no deaths and no super serious, adverse events leading in death or congenital anomalies or, like I said, any other big issues like that, resulting in hospitalization, that kind of thing. And one other thing I will say is that there were no clinically significant changes in vitals. ECGs, labs were reported in the study. And then there was no evidence for increased SI or suicidal behaviors compared to baseline. And that was measured by the Columbia scale that you all know and love. Okay, so just to talk about the study as a whole a little bit. So, these rapid antidepressant effects do support the development of a neuroactive steroid GABA A receptor positive allosteric modulator to use in the treatment of PPD. And these can be used as potential fast-acting antidepressants. What we learned about brexanolone is that, it was FDA approved for this reason. And there are a lot of hospitals and providers that are using this medication because it has shown, that it has worked. It was fast-tracked since it was a novel drug, but it is something that, has been shown to work really well. So this was the first phase 3 randomized control trial for zuranolone, and it did demonstrate a rapid, which means by day 3, and clinically meaningful and sustained antidepressant effects, as well as improved anxiety and then improved global and maternal functioning, all compared to placebo. So, even though they stopped the dosing after 2 weeks, it demonstrated sustained effects, over all the time points. So from day 15 through 45, we saw that the zuranolone group had lower HAM-D scores than the group placebo group. All right. So some of the limitations that we will discuss, obviously breastfeeding is a big one because you can't talk about pregnancy or postpartum period without talking about breastfeeding. That's a huge part of maternal well-being as well as baby's well-being as well. So that's something that I'll actually talk a little bit about in just a few minutes. I have a few slides on a very, very small study that they did, but there's not a lot of evidence on this just yet, especially because zuranolone is very new and we don't know a ton about it just yet. The other thing I'll mention is there were, like I said earlier, there were a few people, I think 4 in the zuranolone group and 6 in the placebo group who started new antidepressants during the trial. So like I said, the question was it the zuranolone that improved their HAM-D scores? Was it the other antidepressant that was started, or was it a combination? Now, we all know that, some of the antidepressants take a while to start working. So it's a little bit unclear, but, some people that start on SSRIs will say they notice a difference within a few days or a week. So it is pretty, I think it's pretty unclear what exactly the answer is for this. The other limitation is the cost. We don't know how much this medication is going to be because it is not FDA approved yet. It is probably going to be more cost effective than the brexanolone. I don't know how you can top the $34,000 and the other cost of monitoring, because this medication, might require you to follow up in the outpatient setting a few more times than normal. But other than that, it's a pill. The pill could obviously be expensive, but we just don't know enough about it yet because it hasn't come on the market. And then the other major limitation was that there were high placebo response rates. Like I said, this could be from many different things. I think in general, women struggle with during pregnancy, and then some people get better after they deliver in general. Another thing is, like I said, a lot of women will will usually function a little bit better as weeks kind of go on in postpartum period, because they're adjusting to, their life with their new baby. They've kind of figured out some of the tips and tricks that they need to in order to kind of cope with what's going on. So that could also be something to look at. But, like I said, the brexanolone studies also had high placebo response rates. And I know that a lot of other antidepressant studies have also have had high placebo response rates. So this is something that I think we see across, across a lot of different studies with depression. One thing that I actually, I'm really glad that I talked to Dr. Hedinger about. So she's one of the women's mental health psychiatrists here in Louisville. She did a few of our didactics a few weeks ago, but her and I spoke about the trouble with diagnosing postpartum depression. So, there's very strict criteria of what postpartum depression is, and the time period is pretty constraining. And it's also, a lot of people don't just have one diagnosis. They have PTSD, they have anxiety, they have personality disorder, they have substance use disorder. So I think sometimes it's really hard to tease out that pure postpartum depression diagnosis. And so, the use of this drug for postpartum depression, I think we all just need to be aware that there are other things that could be contributing to their depression. And it's not just, the decreased allopregnanolone or other things going on. They had a relatively small sample size, even though they had adequate power. And then they also had a pretty short follow-up period. So the true sustainability of this drug is not known, although it is kind of shown to be like more of a rapid acting antidepressant. So you're not going to have to use it for a longer period of time, like SSRIs or SNRIs, et cetera. And then of course, it's not FDA approved, as we've already said. So they're continuing trials as we speak. This is just a little table I wanted to include so you guys could see. So this includes all the patients in the zuranolone group and all the patients in the placebo group. And it shows you how many people had another diagnosis of something. So obviously, there are a lot of people that had comorbid major depressive disorder. And then of course, a bunch of people had anxiety disorders, and they didn't include substance use or personality disorders on here either. But, because all people with bipolar, schizophrenia, or schizoaffective were excluded. So there were a few things they did not include on here. So, people are not supposed to be using substances if they're on this, if they're in the study. But it's just something interesting to see and keep in mind, because, anxiety, if only maybe 15 here and 12 people here had anxiety, but the HAM-A scores were consistently lower. It's just interesting to see how many people it actually improved anxiety in who maybe didn't have a diagnosed anxiety disorder. All right, so this is a small study about evaluating breast milk concentrations. I thought this was important enough to kind of mention. This is just a super small study of 15 people. It did not have a placebo arm. So this is part of Sage Therapeutics. They actually presented this at a virtual congress in 2021. This is not like published in a journal. It's not peer reviewed. It is just like a very quick kind of blurb on what they have seen. So this study was 15 women at a single center who were healthy females, 18 to 45. They were over 12 weeks postpartum and actively breastfeeding, lactating, or pumping at least 3 times a day. So they were given the zuranolone drug for 5 days, 30 milligrams for 5 days. And then their blood samples were collected for PK and peak plasma binding analysis on days 1, 5, and 6, and then 7, 9, and 12. So their primary endpoint to this study was to measure the concentration of zuranolone that was transferred into breast milk. So one thing to mention is that zuranolone was found to be very highly protein bound. Its free fraction was only 0.52% across participants. So these charts look a little bit crazy. This one is just showing the concentrations in milk over time. So it's very variable in people. And we all know that breast milk variation is very common. So that is not, super surprising to see. But the main thing that I wanted you guys to see was this box right here. So compared to maternal dose, the amounts of zuranolone in the breast milk were low. So the RID, or the relative infant dose percent at day 5, was 0.357. So day 5 was the last day that they took the medication. And then, averaged between days 1 and 11, it was 0.314%. So the relative infant dose of 0.357, that correlates to an infant dose of 0.00124 mgs per kg per day on day 5. So very, very low is what they found. Obviously, there were a bunch of limitations to the study. There's obviously major variability in intersubject milk production at baseline, and they did not have a placebo arm, and it was a very, very small sample size. So just, something to think about, but it seems like it does not transfer into breast milk all that much. One thing to kind of wrap up the presentation, I did want to show you the zuranolone graph versus the brexanolone graph for the HAM-D response, the HAM-D total score. So the brexanolone, this is actually, these are 2 studies combined here. So, it shows you the over time in their day, the end of infusion here was at 60 hours. So, they did have a significant decrease in HAM-D and people in the brexanolone group. And then, but as you can see, the placebo, got actually, the placebo was higher towards the end, which is what we were seeing in the zuranolone as well. But, the brexanolone clinical trials, the reduction was only 14.6 points on the HAM-D in brexanolone versus 12.1 in placebo. So just so you guys know, brexanolone was FDA approved for use in postpartum depression. Zuranolone has not been. But based on what I have seen, the results of zuranolone are actually a little bit more promising than the results of brexanolone, and it's oral and, less side effects. It doesn't have like the excessive sedation risk. It doesn't have the loss of consciousness risk as much. So just all things to think about. It is way more accessible for our patients than the brexanolone is. Of course, there are probably most women cannot afford to do this. And it also takes away from women being at home with their baby. So they have to go to a center and sit 60 hours and get this infusion and be monitored and picked out every 2 hours. And when they could be at home with their baby, maybe just taking an oral medication. So just all things to think about. I'm not, dogging on brexanolone. It is actually a very effective treatment for some women. And it's just, development of the oral form was obviously going to happen at some point. So it is in the works as of now. So this chart is just a quick overview of the study. I'm not going to go through this. It's just something that you guys can refer back to if you want to take a picture of it. It's a very quick thing you can refer to if you're talking about it or want to show other people. Maybe send it to some of your OB/GYN friends and just let them know that this exists. It's a very interesting study. All right, so kind of wrapping things up now. So the takeaway is that this study met the primary endpoint. So there was a significant change in baseline of HAM-D scores at day 15. And then I have the response rate and the remission rates in the zuranolone versus the placebo groups and the p-values as well. So you guys can have those in front of you. And then the reduction in HAM-D score was 17.8 in zuranolone group and 13.8 in placebo. And like I said, in the brexanolone group, it was 14.6 in the brexanolone group and 12.1 in the placebo group. So there's a greater difference here than in the brexanolone study. So, as I've said many times, this could be a great fast-acting antidepressant with different mechanism and onset compared with other forms of treatment, such as SSRIs. And then, when compared to brexanolone, the current option, the cost is likely lower and much easier to access for our patients. And so what's next? There are phase 3 trials being completed, and then they are likely to go through the FDA approval process. And this could result in a very promising new treatment for this very debilitating diagnosis. All right, so now I will open it up for questions or comments. Like I said, you can post them in the chat, or you can ask somebody to make you a panelist. And then
sorry. Thank you, Audrey. So what we'll do is we will go ahead. I'm going to go ahead and make all the attendings panelists. Catherine, if you want to go ahead and make some of all the residents panelists. And for whoever does not end up being a panelist, if you just want to click the raise hand button, then one of the moderators, i.e. either Catherine or I, will allow you to talk. So I'll go ahead and start doing that right now. Hey, Dr. Littman, I see that you have your hand up. You're on mute, so we can't hear you right now. You're still on mute, sir. We cannot hear you.
Dr. Littman, you're still on mute.
It might be in the bottom left. Oh, there you go.
Oh, is that better?
Yes.
I think the conclusion here is that we ought to have Dr. Summers be our departmental selected presenter. This was totally dynamite.
It was excellent. It was very excellent.
That's the bottom line. Who knows what'll happen with brexanolone or zananolone, but we do know about Dr. Summers as being a great presenter.
Oh, well, thank you very much.
I really liked your new slides that I hadn't seen before too. They were great.
Yes, thank you. I did add things after you had sent it back to me, and I was hoping that you would enjoy them. So I appreciate all your help.
Thank you. Thank you.
So I actually had a question. So it was kind of if you look at the brexanolone versus zuranolone slide that you posted side by side, one of them is reporting the change in the in percent difference in HAM-D. The other one's recording the least squares means. My understanding is the least squares means is just essentially a line of best fit. Did you, in your paper, did this say anything about what percentage of HAM-D change occurred with zuranolone? Like what was the, so not the LSM, but the actual percentage change? Was that covered anywhere?
They didn't report that. I can probably figure that out, but they didn't report that in the study. Interestingly, I'm not really sure why they decided to measure it with the least square means and not the percentage. But yeah, I can look that up and kind of give you that answer later.
Audrey, again, congratulations on this presentation. It was and is very excellent.
Thank you.
Just a question about the economics of medicine and the economics of psychiatry, in particular with the new medication for Alzheimer's disease and the controversies with even the outcomes of that medication, and now this medication, which is costly and it does require IV administration and close monitoring. There are a lot of women who have postpartum depression, and this seems like such a medication perhaps that will be incredibly effective for a very narrow group of women. I'm wondering what your thoughts are about the cost of medicines and the pharmaceutical companies coming out with medications that are incredibly expensive to both manufacture and to market for just a few people.
Yeah, I mean, it's really unfortunate because I do, what I've heard about brexanolone, it's interesting because not a lot of people, at least providers in Louisville, administer it. I think there are definitely some in Indiana that do, that are kind of more local, but it's very unfortunate that, most of our patients, especially us that are treating like lower income, populations, they definitely can't afford it. I mean, they can't afford some of the, antidepressants that we want to prescribe either. So that this would be a very limited option for those people. But I think, there are a lot of like maternal outreach groups, and there are ways to that people raise money to, be able to support new moms. And, I think the stigma of mental health is lifting a lot in every single, every single category of mental illness, so depression, schizophrenia, et cetera. And there's always a huge there's always a huge want to help new moms and their babies. So I could foresee this becoming like maybe a community thing where, like, oh, my friend, got this medicine. Why don't you check it out? Go talk to this doctor who might be able to provide you resources. So I think as it becomes kind of a more common thing, it might be a little bit more accessible. But, I personally, I hate that we, but we're not able to prescribe a lot of these things for our patients because they're so expensive. And actually, the interesting thing is there are OBGYNs who do this, the brexanolone infusion. So actually, my mom is a nurse manager in Evansville, Indiana, and at the women's hospital there, the OBGYNs they are the ones that prescribe this medication for patients. So this isn't something that just psychiatrists can do. This is something that, OBGYNs should do as well. And, obviously I think there should be some sort of collaborative effort there, because at some point, this may get more complicated and they may need our assistance. So I think, the collaborative model of maternal health as a whole is like really, really interesting and really necessary for our patients as well.
That's a very good point.
Yeah, I actually, what's interesting is that the siloing of psychiatric patients and other specialties, I know this was brought up in some academic hours before, but the fact that the brexanolone was a drug that had to be delivered in an infusion center type situation almost, almost restricted psychiatrists from being involved in that patient's care, because some people might not have privileges at that hospital. Some folks might not have access to an infusion center. So my understanding was that the brexanolone was practically functionally dead on arrival, that it didn't really get as much of a movement as it could have or should have because of because of the way that the drug was developed and marketed as a medical DRG versus a psychiatric DRG. Is that what the attendings here kind of understand as well? Is that the utility was not that good nationally?
That is my understanding. I've not heard of any physician, even locally, that's doing it. So I'm going to check in with some of the OB folks here in town, even in our U of L OB, and see where they refer for this medication.
Yeah, and I thought that John Werner and I talked a little bit about this at one of the meetings that I ran into him in one of the meetings, and we talked about it a little bit because he was talking about bringing this on board. But what's I think it kind of speaks to a larger the politics of it kind of speaks to a larger thing, because the reimbursement rates for mental health code reimbursement and medical code reimbursement are a little bit different. So I think the company might actually be marketing this not to psychiatrists specifically for the infusion. And it wouldn't be the first time that's been done in the TMS space a decent amount too. For the residents and medical students here, any thoughts on the side effect on the placebo response? Actually, why do you guys think it was? And I guess Audrey, you too. Like, why do you think the placebo response for postpartum? You kind of touched on it a little bit, but I mean, the decline, the 3-day response for placebo was really freaking high, right?
I'll let other people chime in before I talk. Okay, well, I guess no one wants to. Like I said, I think, yeah, at day 3, it's really hard for me to like understand why. Maybe they know they're in the study and they're kind of like, oh, maybe they answer the questions a little bit differently. But also, like I said, as time progresses, I think women adjust to their situation a little bit more. And, over time, we'll kind of find those little, things about their baby that they learn, and how to calm the baby down, how to sleep better, how to develop a routine at home. So I think that in general, just improving kind of your environment, and as time goes on, you obviously adjust. So I think that's part of the reason why for the higher placebo rates at the end. At the beginning, it's unclear, but that's kind of my 2 cents of why I think that was.
A follow-up question was that
Another thing
go
might be,
ahead.
besides the natural improvement of a person in this situation, the doctor-patient relation should not be forgotten, the TLC component. Somebody was giving you these pills, somebody was shooting the infusion, somebody was monitoring your side effects, they were taking your HAM-D and all these other studies. So you were getting a lot of TLC and hope for the future, and there was promise you might get better. All that stuff is a big deal. That's one of the big deals in any doctor-patient relationship, and in particular in psychiatry. And if you don't have a good doctor-patient relationship, you're swimming upstream. And if you've got a good doctor-patient connection and instill hope, everything gets better.
Right. And knowing that they're coming in at multiple days to, do this testing and see the provider, I think gives people, like you said, gives people hope. But also, after your delivery, your, hormones drop significantly, right? And then over time, your body readjusts to, the level, and the levels kind of will regulate themselves over time. So it's not like your allopregnanolone level stays like, your body has to adjust to that rapid decline. And that's what they say that maybe causes postpartum depression. So as time goes on, your body may adjust and your receptors may adjust to what's going on. And then you don't feel as depressed anymore either. So that's just something else I'll mention as well.
Yeah, and I also feel like I should mention, because I don't know if you covered this or not, because there were a couple slides that you talked about the specific scales for depression. But the postpartum depression, the understanding of the pathophysiology is that it's actually distinct from major depressive disorder, right? So it's related to a hormonal decline, et cetera. But the HAM-D measures general depression, which can exist for, it's a tool that's specific to depressive states, not necessarily to a specific pathophys for the depression. These drugs that are marketed towards postpartum depression, they target a specific pathway within the hypothesis of what causes depression in these specific patients. But do you know of any like scales or anything like that are, or any kind of biomarkers that people are looking at, maybe the company is looking at, or folks know how to look at them, that tracks depression related to this specific mechanism, right? Because the HAM-A and the HAM-D might measure you improving because your mom came over to help you take care of your baby halfway through the, on day 2, that your HAM-D scores will respond to the fact that your mom came over. But is there anything that's a little bit more specific to postpartum depression, because that's specifically what this drug is trying to target?
Yeah, so the only thing that I know for sure is that the BIMF, which is the Barkin Index for Maternal Functioning, that is one that doesn't focus on depression. That focuses more kind of like on like motherhood as a whole. That's not necessarily what we are looking at specifically. So I always wonder, in these studies, like why they pick certain things and why they pick certain scales and not others. The HAMD, after looking through it and reading through the questions, I actually don't really like it that much. It's just, I don't know. It just seems kind of odd for what we're testing for. I agree with you. There's not, the only thing, like I said, is the screening for postpartum depression. That's not to measure it. So that's the Edinburgh is the only one I know about. That is a really good question that I can ask. A couple of the SAGE reps too, and like why they use that HAMD instead of something else. And there may just not be anything that exists that covers, specific symptoms of postpartum depression. So that would be actually something really interesting to look into for the future, because I think we do need something that's a little bit targeted for that, and that covers more than just, your typical depression symptoms.
Plus, the FDA always like biomarkers, so they'll probably want something like, especially if this is like a allosteric modulator of a post cholesterol / hormone pathway. So that might be kind of something interesting to think about too. And just for the folks that are actually panelists that are residents here and some of the students, do you guys know what a CGI is, by the way? Because CGI, weirdly enough, is reported in a lot of psychiatric studies. And I know that we know what it stands for, but do you know actually what it is? Any of the students or residents here know what it is? So it's called the Clinical Global Index, but it's at one point in time, it used to be called the Clinician Global Impression. Essentially what it is how you as a researcher thinks that the patient is doing. And so I think it's a proven fact that physicians are very poor at predicting at saying at very poor at like correlated with how the patient is actually doing. We tend to over correlate. We tend to be overly optimistic about our own treatments. And so beware of any study or any drug rep that says that the CGI improvement was 80%. That just means that the physician thought that they did well 80% of the time. Does not reflect any kind of patient outcome.
Audrey, again, I'm really glad you picked this topic. I think postpartum depression, postpartum psychosis, postpartum mania is very hard to handle as a physician because you're dealing both with the mother and the child. And for those of you who work in emergency psychiatry, you often have patients who come in brought in by families who are postpartum with either depression or odd behavior. I guess the family usually says they're just not doing well. You have to be extremely cautious because all of us probably have seen people who have killed their children or have killed the baby or have really tried to kill themselves because they minimize their symptoms. They want to be a good mother, but they know something's wrong. And perhaps this medication is for people who are just at that threshold, although ECT had been used quite a bit for patients who were postpartum, or at least hospitalization, treatment with antipsychotics. Again, I have patients who come in, and as Dr. Al-Malik says, if a patient looks psychotic at postpartum, they're probably bipolar. It's not a postpartum depression. It's a bipolar illness with a depressive episode postpartum. So you really have to, in an emergency room, you don't have time to do all those scales. And you're right, we're not very good at assessing our treatment options, our outpatient treatment options, and our outpatient outcomes of patients who've been treated. So I would encourage any of you who are in the emergency room to err on the side of safety and put them in the hospital, at least to really figure out what's going on and get the family involved, because postpartum depression or bipolar illness or psychosis is a family illness. everybody's involved because of the baby.
Yeah, no, that's a really good point, Dr. Vincent. I appreciate your input. And, I will say one of the biggest things one of the things I've learned the most throughout this process of, doing this journal club was in talking with other providers and other people is that, we don't ask about pregnancy as much as we should. And it should actually be as often asked as things like substance use. Is there any way that you could be pregnant? Do you plan on getting pregnant soon in the future? Because that changes your treatment plan, from day one, even the first day you're seeing them. And so if you don't ask those questions, it's hard because a lot of our patients are not on birth control. And so asking about that is important. A lot of them will go and get pregnant and not plan it. So I think it's just really important to ask because it really changes your treatment. Like you're not going to put somebody on Depakote who's like, oh yeah, my husband and I are trying to have a baby, or, like, oh, I'm having a lot of unprotected sex, So I think it's just really important to ask. I've talked to a few different people about it, and I feel I'm guilty of this as well. And I'm not saying do a pregnancy test on everybody who comes in necessarily, even though maybe they should, but talking with them about their plans and their, history with pregnancy as well.
I think you should do a pregnancy test on virtually every pregnancy capable person when you're seeing. I do. I mean, in fact, I got quite interested in HCG testing, and I'm talking about serum HCG, not a urine pregnancy test. Urine pregnancy test is almost like just asking a question, but HCG tells you within days, and there's an exponential increase in the HCG level.
Mm-hmm.
Some people might even have a positive test, but it won't exponentially increase if they're not pregnant. I mean, there's
Right.
other reasons for HCG to be up, including postmenopausal women and other reasons, but with pregnancy, it goes up like a rocket ship. And as an outpatient doc, I do a pregnancy test on nearly everybody that comes in.
Mm-hmm.
How many times have you had patients get pregnant on Depakote? Because I've had them get pregnant on everything.
Yeah,
Depakote, and lithium, everything, and
everything, all the time.
It is.
When you're taking a history, you have to remember you're talking about human nature.
Yes. Yeah, absolutely.
We are all frail creatures.
Does anybody else have questions or comments or anything before we end the meeting?
All right, good job, everyone. Good job, Audrey, and thanks everyone for participating. I'll stop the recording here. And all right, thank you, everyone.